Hello, my name is Don Duffy, Director of Panhandle Health District. I wish to welcome each of you to today's North Idaho Substance Use Summit. Your attendance demonstrates your dedication and commitment to turning the corner on this public health crisis of substance use disorder. May I share two statistics associated with this crisis? From May 2020 to April 2021, over 100,000 people died from drug overdoses in the United States. In addition, North Idaho emergency room visits for non-fatal opioid overdose increased by nearly threefold since 2017. Today's North Idaho Substance Use Summit is part of Panhandle Health District's ongoing objectives originating in 2017 to address the ongoing challenges associated with substance use disorder. I hope that you will be an active participant in today's summit as presenters discuss SUD prevention, harm reduction, treatment, and recovery. Thank you to the presenters, community partners, funders, and Panhandle Health District team members for making this summit possible, and especially to each of you for attending. Together, we can prevent and reduce the suffering associated with substance use disorder. May I now introduce Liz Bryant, Director of the North Idaho Area Health Education Center.
Good morning, everyone, and welcome to the 2022 North Idaho Substance Use Summit. I'm excited to see such a robust audience, and I think this is truly a testament to how important this topic is for such a wide segment of our community. My name is Liz Bryant, and I direct the North Idaho Area Health Education Center, or AHEC, a grant-funded program hosted by WWAMI Medical Education at the University of Idaho. Idaho WWAMI and North Idaho AHEC are committed to developing and sustaining programs and partnerships that enhance healthcare access and delivery, with a focus on primary and preventative care for rural and underserved communities. Preventing and addressing substance use and addiction is arguably more challenging and more important than ever, with repercussions of the COVID-19 pandemic triggering an unprecedented increase in overdoses and overdose deaths. This issue impacts every corner of our state, but we know these effects can be amplified in rural communities where resource limitations and geographic barriers can impede access to support for prevention, treatment, harm reduction, and recovery efforts. Thank you so much for your commitment to be here today. Panhandle Health has arranged a full schedule of outstanding speakers, and we are so grateful for this opportunity to connect and collaborate with all of you.
Hello, my name is Kevin Hudgens. I'm the Idaho Drug Intelligence Officer with the Oregon-Idaho HIDA, along with Karen Kershaw, who is our public health analyst. We will be going over public health and public safety overview of drugs in Idaho. In our presentation today, we'll provide an overview of the overdose response strategy, the illicit drug supply in Idaho, public health implications of fentanyl, overdose data, and some ORS projects that we are working on. Next slide. And this is our contact information if anyone needs to get a hold of us. And this is our disclaimer that the contents are those of the authors and do not necessarily represent the official views, nor an endorsement by the CDC, HHS, or the United States government. So the overdose response strategy in Idaho is a collaboration between public health and public safety created to help local communities reduce drug overdoses and save lives by sharing timely data, pertinent intelligence, and innovative strategies. How we do this is by enhancing communication between public safety and public health. For instance, sharing timely data could include sharing overdose and overdose death data to public safety, and pertinent data could include the types of drugs our officers are seeing out in the street, and then sharing that data back with our public health partners. This is the Oregon-Idaho HIDTA, high-intensity drug trafficking area, and the areas that are shaded in blue are those areas that are designated as high-intensity drug trafficking areas. HIDTAs are established by the White House Office of National Drug Control Policy through a petition process which outlines why the area is a critical drug trafficking area. Once designated, the area receives federal funds to establish a task force approach, as well as funding our domestic highway enforcement program. The strategy of HIDTAs are to identify and target drug trafficking organizations and money laundering organizations to disrupt and dismantle these groups. In Idaho, we have 4 designated areas considered HIDTA counties, and those are Canyon County and Ada County, Bannock County, and Kootenai County. This is a map of the United States, which shows the various HIDTAs operating within the United States. We have HIDTAs in every state, including Puerto Rico, Hawaii, and Alaska. The illicit drug supply in Idaho. We'll talk a little bit about what we're seeing and what that looks like. So recently, the Oregon-Idaho HIDTA just finished our 2023 threat assessment. And what that is an annual analysis of drug trafficking and related activities taking place in Oregon and Idaho. It also includes what we feel are going to be the greatest threats moving into 2023. And this document is unclassified, and I encourage everyone to go to the Oregon-Idaho HIDTA website and review this document. There's actually some very good information in there. So from the findings from the 2023 assessment of the top drug threats in Idaho, what we've identified moving into 2023 is that we believe fentanyl will be the most significant threat. This is somewhat unusual because in the past several years, methamphetamine has been the top threat in Idaho. The reason why we feel fentanyl is moving into that number 1 spot is because it's easily available, it's cheap, and it's easy to use. It's being pushed into the state by drug trafficking organizations in large quantities. And what we've primarily in Idaho, we see fentanyl in pill form, but increasingly we're seeing it in powder form. There are 2 types of fentanyl: pharmaceutical fentanyl that is prescribed by a doctor, and then illicit fentanyl, which is what we are talking about today. Number 2 is methamphetamine. While methamphetamine is number 2, we still see this as a critical threat in Idaho. It's readily available, it's cheap, but although lately we've seen the price starting to increase again. And one of the other things we've seen is that it's very high in purity. We're seeing routinely above 90% purity. It's found in 43% of drug samples submitted to the Idaho State Police Forensics Lab. And typically we see it in crystal or ice form. Our number 3 threat is heroin. It's widely available, but the demand has decreased. And one of the reasons we feel that why the demand has increased is because of fentanyl. There's not the stigma with heroin where I have to stick a needle in my arm. With fentanyl, I take a pill. And fentanyl is cheap, and heroin still remains somewhat cost prohibitive to some users. And then the number 4 threat is marijuana. Typically, we see a lot of marijuana coming from our neighboring states who have legalized marijuana, but that is our number 4 threat. So fentanyl, again, is a quickly emerging threat. Illicit fentanyl is a synthetic opioid manufactured by cartels in Mexico and imported in powder or pill form. Mexican cartels get their product from China, and then once it is in Mexico, typically they are pressed into counterfeit pills, that are made to look like pharmaceutical OxyContin or oxycodone, those types of things. The problem with the Mexican cartels making fentanyl is there is no quality control in their production methods. It's widely inconsistent. That's why we see oftentimes we'll hear stories about two people sharing a fentanyl pill, and one person takes one half and the other person takes the other half, and one person ends up either overdosing or dying while the other person doesn't. Just to give you an example, the Oregon-Idaho HIDA seized 1.5 million counterfeit pills in 2021. This is a 51% increase over 2020 and 137% increase over 2019. In 2022, we anticipate with the Oregon-Idaho HIDA area of operation seizing over 3 million illicit fentanyl pills. The fentanyl is also found mixed with other drugs. We're increasingly see that, like heroin, meth, and cocaine. One important note to note is that the ISP lab has not seen fentanyl mixed with marijuana. There have been stories floating around out there with that, but our lab, the ISP lab, has not seen that. And this just gives you an idea of what we're seeing in the Oregon-Idaho HIDA area. In 2017, the number of seizures, 1,917 dosage units. That dropped a little bit in 2018, rose tremendously in 2019, and you can see the number in 2020 and 2021. And again, in 2022, we expect that number to be over 3 million dosage units, and we consider a dosage unit a pill. So that concludes my part of the presentation. I will now turn it over to Karen Kershaw, who is our public health analyst for Idaho, and she will talk about the public health overview of drug use in Idaho.
Hi, my name's Karen Kershaw. I'm the public health analyst for Idaho, and I work for the CDC Foundation on the overdose response strategy with Kevin. All right, so now that Kevin has given us an overview of the illicit drug supply in Idaho, what I'd like to do now is look at the public health side of this crisis. So I'm going to go over some overdose data that we're seeing nationally and across the state, and then talk about some projects at the intersection of public health and public safety that Panhandle Health District is working on. So nationally, we are seeing unprecedented numbers of drug overdose death rates. So this headline made the news back in November, and it was the first time in our country's history that we've seen more than 100,000 drug overdose deaths over a 12-month period. This was a 30% increase from that same period in 2020. And another milestone from this headline was that most of these deaths were driven by fentanyl and other synthetic opioids, and psychostimulant deaths also increased during this time. So this marked a shift in our experience in the drug overdose epidemic, and a shift in how we need to think about responding and preventing drug overdose. So narrowing down within the state of Idaho, our numbers are tracking pretty similarly to what we're seeing nationally. Our drug overdose deaths increased in 2021 as compared to 2020. The percentage of those deaths that involved synthetic opioids also increased during that time, and as well as the number of drug overdose emergency department visits in that time. I also wanted to show that the prescribing rates in Idaho have decreased as well over the past couple of years. I believe we're still a little higher than the national average, but you can see that that number has gone down quite a bit. I'm not going to get into prescribing policies or practices today, even though that's really important. It's really outside the scope of Kevin and I's work. But I did want to show that those numbers have come down. And again, it's marked this shift where prescription opioids are no longer driving most of our deaths like they have in the past. We've entered a new, some are calling it the third wave or even the fourth wave of the drug overdose epidemic. The first wave being driven by prescription opioids, and then that transitioned into heroin driving most deaths. The third wave is kind of where we're at now. where synthetic opioids and fentanyl are driving the majority of deaths, as we've seen. Some are saying that we're actually in the fourth wave of this epidemic with the rise of psychostimulant deaths and polysubstance use. And so again, a lot of what we're seeing and the increase in numbers that had recently been plateauing is due to the presence of fentanyl in our illicit drug market. And so I want to talk about some of the public health implications of that and the work that's being done around it. So this is a slide that was taken from Song for Charlie, which is a nonprofit organization. And this data is from a national survey that was done last year, and it was in partnership with Snapchat. Snapchat is a very popular method for purchasing and finding drugs. And so they sent out a survey and they asked different age groups to talk about their mental health and their perceptions of different substances and how dangerous they are. So this study came across our HIDA office, and there were a couple of things that caused us concern with this data. First of all, 23% of those who answered the survey said they didn't know enough about fentanyl to rate how dangerous it was. So that's problematic in itself. And those who did feel that they could rate how dangerous it was, you can see on the right that it was more common for heroin or cocaine to be rated as extremely dangerous than fentanyl. And of course, we know that the lethality of cocaine and heroin on their own is much lower than fentanyl. And on this slide, you can see that they highlighted the death rate for each of these substances. And I'm not sure if that's for just this age group or for the whole population, but of course you can see that the death rate for fentanyl is much higher than those other substances which were rated as more extremely dangerous. Another concerning point in this data was that 60% or 59% of respondents hadn't heard of fentanyl and counterfeit pills. Again, this study is from last year, so things might have improved since then. There's been a lot of messaging and campaigning around this topic, so numbers might be better if we were to administer the survey again. But again, what this all points at is that fentanyl has come into the drug supply market so quickly and changed things so quickly that it's created this gap in knowledge, especially in this age group of Gen Z, of 13-year-olds to 24-year-olds. So what this data points to is a gap in knowledge, especially in young people between ages 13 and 24, Gen Z, when it comes to fentanyl and counterfeit pills. So one, they may not know what fentanyl is, they might not have heard of it. Two, they may not know that the pills that they're experimenting with or using to self-medicate are counterfeit. If they do know they're counterfeit, maybe they have a hunch that they're not real pills. They may not know that those pills contain fentanyl. And even if they do know that they contain fentanyl, they may not know just how dangerous fentanyl is and exactly what they're gambling when they take that pill. So one of the things that we did in response is that we put out this bulletin in April. And this contains information on a lot of the data points and the information that the previous slide touched on. It talks about fentanyl and where it comes from and why it's coming into our state. It talks about mental health in youth and why young people might encounter these pills or seek them out. And then on the back, it provides actionable steps for schools and parents to take to mitigate the risk of fentanyl with their loved ones, with their school, with the young people in their lives. So this came out in April of this year. The information on here is still up to date. And so if anyone in the audience wants a copy of this, we can provide that to you with the other resources you're getting after the conference. Feel free to disseminate this within your networks, within your organization. Our priority is to get this information out there and try to make smaller that gap in knowledge that we have noticed. So now I'm going to switch gears and talk about two other projects that again are prime examples of public health and public safety working together, and they just so happen to both be taking place up here in North Idaho. The first project is called ODMAP, and this is a data project. ODMAP is an online data platform for first responders and public health agencies, and what it does is it takes overdose data from law enforcement EMS agencies and it populates it into this national map. So every point on here represents an overdose. The diamonds are a fatal overdose, and the circles represent a non-fatal overdose, and the different colors signify if and how much naloxone was used. So first responders provide this data to ODMAP, and then agencies like Panhandle Health District can get access to this data and then get real-time information about when and where overdoses are happening in their community. So you can see on this screenshot from a couple weeks ago that there are some overdose data points up in North Idaho. So Panhandle Health District has had access to ODMAP since October 2021, and they have a agreement with Kootenai County EMS system. And so since October, any overdose to which EMS responds to in Kootenai County, Panhandle Health District has access to that data, and they'll get an alert in real time of when and where that overdose happened. So one useful tool that's built into ODMAP is the ability for Panhandle Health District to distribute spike alerts in the event that there's a sudden increase in overdoses in Kootenai County. So if there's more than, I believe, 3 overdoses in 24 hours in Kootenai County, Panhandle Health District will be alerted. And they have a wonderful team of specialists that are daily and weekly monitoring ODMAP, and then they'll do some case investigation in the event of a spike to determine some of the information and the causes around that spike. Then Panhandle Health District will issue a spike alert, and they do that through social media and through press releases, and they provide some concrete, tangible steps for individuals to take to protect themselves, as well as some information about what's causing that spike based on their intelligence. So anyone can sign up to receive an email spike alert from Panhandle Health District, so I encourage you to do so if you haven't already. But I just wanted to highlight the work that Panhandle's doing with ODMAP. They're really leading the rest of the state, and I would say even most of the country, in how they're utilizing this data and using it to inform their overdose response and outreach work. So I wanted to wrap up with another project that's taking place at Panhandle Health District, and that's Idaho Law Enforcement Diversion, or ILED. So this is a new program that launched July 1st, and it creates a linkage to care from the point of arrest. It's a partnership between Panhandle Health District and Idaho State Police. And so essentially what this looks like is if an Idaho State Police officer is on patrol and they come across someone in possession of a small amount of a controlled substance, instead of arresting that person and taking them to jail and charging them with a felony, instead they'll give that person a card to call a case manager. That case manager will assign that individual to a treatment provider. We have several treatment providers in Kootenai County in partnership with this program, many of which I think are here today. And so once that person gets assigned to a treatment provider, they'll get substance use treatment and case management services free. So individuals will get that treatment and get those services for a year or longer. But at 1 year, they can graduate from ILED, and at that point, those charges are dismissed. And so that felony charge will never go on that person's criminal record, or if they don't have a criminal record will not be created. So ILED is just one of many of these types of programs happening across the country and also right here in Idaho. So while we're standing this program up in North Idaho, what we're also doing is bringing together all of the diversion programs in the state and creating this coalition of these diversion efforts that all have the same goals that are on the screen here: to reduce overdose, reduce recidivism, reduce the utilization of emergency department services and EMS services, increase the use of non-emergency behavioral health services, and we also want this program to help law enforcement as well. And so we're hoping that it'll reduce stigma and compassion fatigue among law enforcement officers, because now they have another option rather than just arresting people, sometimes the same people again and again. And instead of having to go through the process of booking them and taking them to jail, they can instead just refer this person to a case manager and then get on with their shift and spend their time looking at more serious crimes. So with that, I'd like to thank you for your time, and we are looking forward to answering any questions you may have.
Hi, my name's Lois Gilmore, and I am from SAMHSA, which is the Substance Abuse and Mental Health Services Administration. I work in Region 10 in Seattle, and so Region 10 is comprised of Alaska, Idaho, Oregon, and Washington, and 272 federally recognized tribes. Prior to SAMHSA, I was a clinical social worker, and so I've worked with all different ages, 2 to geriatric and residential treatment, psychiatric hospitals, substance abuse, and outpatient. And so I'm really excited to be here today, and I just want to thank the Panhandle Health for inviting me to present. And thank you for being here, and thank you for your time also. So with that being said, I'd like to just tell you a little bit about SAMHSA. And the mission of SAMHSA is to reduce the impact of substance use and mental illness on America's communities. And they do that through believing that behavioral health is essential to health, believing that prevention works, that treatment is effective, and people do recover. Then SAMHSA's priorities and cross-cutting principles are, their priorities are enhancing access to suicide prevention and crisis care, promoting child and youth behavioral health, integrating primary and behavioral health care, using performance measures, data, and evaluation, and preventing overdose. We all know that overdose has really spiked since the beginning of the pandemic. And so their cross-cutting principles are equity, workforce, financing, and recovery. Through our offices and centers, SAMHSA provides leadership, resources, programs, policies, and information, as well as data that's needed to advance mental health and substance use disorder prevention, intervention, treatment, and recovery services. Region 10 is very diverse in its geography, its beauty, its culture, and its residents. And a part of our diversity is our LGBTQ community. So what does LGBTQIA+ mean? So going back to the title of today's presentation, sometimes acronyms change, and so I just wanted to go over what it means. So it means lesbian, gay, bisexual, transgender, queer or questioning, intersex, asexual, and the plus sign is a symbol that represents members of this community who identify with orientation or a gender identity that isn't included within the LGBTQIA acronym. So within today's time and scope of my presentation, I don't have time to go over each of the terms listed above and the many terms that are used within the scope of the LGBTQ community. We could do an hour or more defining the terms and describing the differences. However, I will provide you with electronic handouts that will define these and help to clarify any confusion. And I'll ask that this information is emailed to you. I'm going to begin with a small graph, and this is regarding LGBTQ plus youth reporting a suicide attempt in the past year. This is recent information that comes from the Trevor Project, and the survey was conducted between September 20th and December 31st of 2021. They gathered information through this survey from 33,993 people ages 13 to 24 years old. And they all identified as being LGBTQ plus. So when we look at this, the data demonstrates that high levels of trauma symptoms correlate with high levels of a suicide attempt. The high levels of trauma symptoms, those individuals have 3 times greater odds of attempting suicide in the past year than those with low to moderate symptoms or no trauma symptoms at all. So today, we'll learn about the connection between trauma, substance use disorders, and mental health in the LGBTQ plus community and population. There are high percentages that correlate for this group, and it is higher than the general population. So, to begin with, there are barriers that create or exacerbate the LGBTQ disparities. And so there's 4 areas that we look at, and one is accessibility, and that's the ability to access a service that may be available. Then availability, it refers to services that may not be available in some communities and are available in other communities. Affordability is payment systems and the ability for a resident to afford their care. And acceptability refers to the culture or stigma that may prevent a person from seeking care. So I know in smaller towns or areas where people know each other, a lot of times people are hesitant to be seen at the local doctor's office or the mental health office, the sheriff's department, because they're afraid everyone will be talking about their business or wondering what they're doing, even if they're not doing anything at all. So to go into a little more depth about barriers that are created or exacerbate the LGBTQ disparities, when we look at accessibility, many people have to travel long distances to reach available behavioral health, substance use disorder treatment, or even medical providers. There's oftentimes a lack of public transportation. There may be limited broadband availability in some areas that hinders telebehavioral health services from being provided. And we're experiencing a lack of providers just in general, but then specifically, we have a lack of providers who are culturally knowledgeable regarding this population. And this can also be a barrier. So availability, when we have fewer providers to cover crisis care, mental health, and substance abuse services, it takes longer time for people to get an appointment and to be seen. Then oftentimes maybe it's 30 days, 60 days before they get an appointment. And by that time, they've decided that their crisis is gone and they don't want to be seen any longer. So the other problem is there's like limited access or no access to detox services and affordable treatment. And if a person needs residential or inpatient, that's also frequently difficult to access because it's not available. And one more thing on availability is medication assisted treatment. There seems to be a higher problem with limited access to medications for opioid use disorder than, say, alcohol use disorder. Affordability. The LGBTQ individuals are less likely to have health insurance or to be able to afford medical care. Areas with limited behavioral health providers may not accept insurance plans that have a lower reimbursement rate. There's also inadequate behavioral health parity when it comes to insurance payments. And frequently, they are unable to pay cash for services or to cover their copays. And then acceptability. There's a higher level of stigma associated with substance use disorders. People seem to think that if you were just stronger willed, that you could just quit. And so people just in general are stigmatized if they have a substance use disorder. And then after that comes mental health care. That also carries a stigma with it, and just recovery in general. So the LGBTQ community is more susceptible to stigma surrounding behavioral health care due to past discrimination that they've experienced. And there are fewer choices of trained professionals that are comfortable with treating this population, or they don't feel comfortable because they have a lack of knowledge. And then the community also has concerns regarding their lack of faith in confidentiality because sometimes they're not explained how and what can be shared about their medical record and about their use of substances. So these all create obstacles to accessing health care. And I know, like in Alaska, there is a veteran that has to travel something like a crazy distance, like 600 miles to go to Idaho to see his provider via telehealth. And that's one way. And so that is just so prohibitive, to travel that kind of distance to get the care that he needs. And so other things that are obstacles is maybe not being able to afford the out-of-pocket costs for the services, being uninsured or underinsured, social stigma, as well as self-stigma surrounding mental health services and substance use disorder services. Individuals report being discriminated against or spoken harshly to, and they may feel that their health care needs are not private. SUD clients are the most disenfranchised group, with mental health being second, as I said earlier. And then pair this with being LGBTQ, and it becomes difficult for individuals to seek help and services that they really need. So another thing that I found, not necessarily in the gay community, but with the veteran population, they would frequently not be able to afford like a smartphone or a notepad that was capable of doing Zoom and video conferencing for their telehealth appointments. And so the VA would provide them with one, and then they would drive up the road to get a internet signal because there wasn't one at their home. And then the signal might come in and out and be weak and drop. And so that would impair their ability to get services, even if they had adequate computer or notepad to do that with. So then mental wellness and substance dependence. Research has shown as far back as the Vietnam War that relationships and belonging lead to happiness, health, and resilience. And so then the opposite would be true. Exclusion, rejection, lack of acceptance would lead to mental instability and increased substance use. Suicide is a key concern with LGBTQ individuals. It is the leading cause of death for LGBTQ aged individuals 10 to 24. That's really sad. And then transgender individuals experience suicidal ideation as well. 65% report suicidal ideation, while 40% reported a suicide attempt. And most of these attempts were before the age of 25. So causative elements that causes is lack of support, harassment, substance abuse, mental health disparities. So mental illness is 2 to 3 times higher in the LGBTQ community than it is in the general population. Common mental health issues are depression, anxiety, and mood disorders. And this is true for the adult LGBTQ population as well as the gay and lesbian youth. Substance use, misuse, or overuse is reported at a higher rate in the LGBTQ community. This includes the use of tobacco, alcohol, and illicit substances. LGBTQ population, individuals in the population report 20 to 30% use of mood-altering substances compared to 9% use in the general population. Contributing factors include a lack of support. Everyone needs a cheerleader, someone to tell them that it will get better and they can do it. Substance abuse causes thinking errors. With the use of harm reduction, sometimes it can help one's ability to think clearly, and having the ability to discuss personal issues and someone's undivided attention and understanding is healing and helpful. So another graph that I have is for the state of Idaho, heterosexuals and LGBs with substance use disorders. So there is no data available for the 26-year-olds and over or for males. But when we look at the 18 to 25-year-old age group and the female age group, we can see heterosexuals are blue and the LGB is in the orange graph. We can see that there's a significantly higher percentage of substance use in the LGB group over the heterosexual group. And so, as we've already been talking, many of those issues and challenges feed into this, causing greater problems for this population. Now, again, in the state of Idaho, to look at this a little different, we're going to look at serious thoughts of suicide in the past year. And so this information comes from SAMHSA, from the Center of Behavioral Health Statistics and Quality, and it's for the years 2015 to 2019. And so you can see each age group, 18 to 25, 25 to 49, and 50 and over. And then we have the male and female group, and we have non-Hispanic white information for both heterosexuals and LGBTQ, and we just have it for Hispanic heterosexuals. But I thought this would give you some good information to see where your area compares to the others, because I'm going to show you some information on Region 10 and for the United States. But going back to this particular graph, we can see that in the 18 to 25-year-old age group, that is 3 times higher than that of the heterosexual group to have serious thoughts of suicide in the past year. And it's 5 times higher for the females that are LGBTQ over the heterosexual females. And that's a dramatic difference. And so this shows how important suicide prevention and behavioral health services become when we're working with this population. Suicide and suicidal thoughts tend to go up with someone who's intoxicated or using illicit drugs. And then this magnifies the importance of working with the whole person and addressing all their needs to improve the medical outcomes and success in quality of life improvement and satisfaction. So the next one, like I said, this one is going to be for Region 10. And so this one breaks down. We have more information in the different race categories, but still just one LGBTQ for the non-Hispanic whites. But we have both male and female information, and we have both 18 to 25s and 26 to 49 years old. So this shows in the past year what are the percentages of that population that have had a substance use disorder. And so for the 18 to 25-year-old heterosexuals, 14.5% had a SUD disorder. And for the LGBTQ community, 18 to 25, it was 19.9. So almost 25%. It's almost a 5% increase. And then for the 26 to 49-year-olds, it's a little greater. It's 11.4% having a substance use disorder. For the heterosexuals, and 19.5% for the LGBTQ community. And then when we go to males, the heterosexuals, 11.1% had a SUD, substance use disorder, and with the LGBTQs population having 16.3%. And then the females are really remarkable, because the heterosexual female is 6.8% with a substance use disorder, and then the LGBTQ female has 16.9%. So that's right there at 3 times more substance use disorders for this population. And then when we look at the Caucasians, we've got 8.9% of the white heterosexuals having a substance use disorder overall, and the LGBTQ Caucasians, 15.2%. So some really interesting information that comes out of this gathering of data. So then we'll go down. And Region 10 having serious thoughts of suicide. Here's this graph. It shows that it's significantly, the blue category is the heterosexual and the orange is the LGBTQ category. And so anything that's different by 0.05 is considered significant. And so, as this graph shows, there's serious thoughts of suicide that's significantly higher with the LGBTQ groups than in the heterosexual groups. This is true for all groups except the 50 and older group that there was no data available for the LGBTQ population. Okay. So now then we're going to look at the United States and see how does Idaho compare with Region 10 we just saw, and now the United States. And so what we see is it's staying significantly higher having serious thoughts of suicide over the past year for the LGBT population. It's like 3 times as high for the 18 to 25-year-olds. It's 3 times as high for the 26 to 49-year-olds. And then for the 50 plus, we're looking at almost 3 times as high there. And for males, it's close to 3 times as high for the number of serious suicidal thoughts in the past year. And the females is close to 5 times higher. And then this one has some nice more information on the different races. So you can also break it down and see which of the races are more susceptible to having suicidal thoughts. And when we look at, let's see, it's the non-Hispanic, more than one race, they are 22%. So that's the highest of all the groups of different populations for the LGBTQ group. So we've kind of looked at the problem. So now then let's begin to look at what are some ways we can improve the outcomes for the LGBTQ plus group or population. What are some best practices to improve how we work with this group so that we can provide better services? And so one of the best practices is just like you're doing today, receive some education regarding the LGBTQ culture, learn more about them. With understanding and education, you know, we are able to communicate and understand. Doesn't mean that we agree, but it means that we understand. And what we found is that it's helpful for a provider, and I'm going to use a provider generically. That may be a doctor, a dentist, a lawyer. It may be a social worker. It could be the man or woman at the front desk or answering the phone. So what's helpful is when we admit that we're not an expert with this population, and unless you are one, you may be an expert, but being honest builds trust. And, you know, honesty is always good for open communication. And that's one of the things that this population has lacked because there's been so much shame and stigma with their lifestyle and so on from the general population. This helps them to be able to open up when we're honest with them. Also, a best practice is that when we're open-minded about our LGBTQ patient, client, you know, consumer, whatever word that you use in your setting, we need to set aside any biases or personal beliefs that we have regarding the group and just work with the individual and try to get to know them and understand them. You know, what do they say? The mind is like a parachute. It only works if it's open. And so we want to stay open-minded. So one way to do that is to ask open-ended questions, not leading questions, but questions that could go anywhere, like the use of motivational interviewing. And so that is an excellent way to find out what the client is wanting and why they're there and what they're hoping will happen with their visit. Another best practice is have your waiting room be a friendly environment for the LGBTQ. You know, be warm and welcome to everyone, treat everyone with dignity and worth. I'm not saying you don't. I'm just saying, you know, to just be aware of any kind of facial cues or body language, you know, and including rather than excluding people. And that's good for everyone. We all want to be noticed and included. Another best practice is when we can integrate behavioral health, substance use disorder treatment, and physical health care all together. And when we have a warm and welcoming team that works together to support this client. And so that person feels like they're not in it by themselves and that they're understood by the people that are supporting them and helping them to achieve their goals. So some efforts that are showing success in addressing disparities include active listening. Nearly 50% of lesbian and bisexual women have not come out to their provider. So we have half of the women that are lesbians that do not share this information with their provider. And perhaps that's important information depending on what the issue is that they're addressing. So when we use motivational interviewing, we are open to learn what the client or patient wants and how they feel. And when we learn more about the cultural language, but not necessarily using their language, then we have a clearer understanding of what they're communicating to us. And so that's also good. Be aware, again, like I said, of your body language and facial expression when you're listening to an LGBTQ patient. When I was getting my degree, we had to be videotaped, and I'm shaking my head because it was a struggle for me. I would ask a question, but while I was asking the question, I was telling the person with my body language what the answer was. So I would say, "You're not drinking too much, are you?" And so that's, where I should have been saying, "How much are you drinking in a week or on a weekend or per month?" rather, and not shaking my head no. And so we want to become aware of our personal behaviors that might be impacting how we communicate with all populations, but especially the LGBTQ population, because they tend to be more sensitive and pick up on these cues maybe more readily than some populations because of the way they have been treated or mistreated. So creating a welcoming clinic environment, how do we do that? Well, one of the things that we've already talked about is good communication skills. So by including appropriate gender pronouns, and I know this probably will go against what some people think and feel, and I'm not saying that you need to change that. What I'm saying, though, is when you're at work and you're working with individuals, it's going to be more successful if you can set that aside, where you're looking at let's say a man, and he goes by a woman's name and wants to be called, referred to by she, her. And I had this happen to me. I had a client come in as my very first meeting with him, and his name was Howard something. And I said, "Hey, Mr. whatever his last name was, I can't think of it. So we'll say Mr. Smith, how are you?" And he goes, "Oh, I'm doing good, except I'm not Mr. Smith, I'm Brittany." And I'm like, and I'm like, okay. So I had to quickly check that because I was really caught off guard. I was not aware of this. And so it was just kind of a road bump where it could have been more of an accident. So we just bounced over that and we talked about it and so on. And then as he got more comfortable, as Brittany became more comfortable, she would come in being more feminine as time went on, and she wanted services for to transition from male to female. And she would talk very openly about her son and experiences she was having with isolation and so on. And so that one moment could have been bad. And so I felt like we both handled it the best we could of that day, that it could have been a lot worse. She could have been really offended and upset that I called her by the wrong, by masculine rather than feminine, and so on. And I could have been upset when I was corrected, but I wasn't. And so, because it wasn't about me, it's about her. So that could have gone off bad, but it worked out really well. So, and a couple of things when we're talking about being open-minded that I wanted to touch on is assumptions. We don't want to assume that a lesbian's never been pregnant, doesn't have children, hasn't ever been in a traditional marriage, or hasn't had sex with a male. And the opposite is true also for the gay men as well. And so sometimes if your LGBTQ client speaks to you in a term that maybe you don't understand, or maybe you thought it was something different than the way they're using that term, then you might just ask them what it means, or what what it means to them, so that you understand and you don't have any miscommunication. So one example too that I wanted to give you is that it's really important, the messages that we give people. I had a male veteran who had been in the Middle East in the war, the Afghanistan, Iraqi war, and he had severe PTSD from this. And so the counselor before me had talked to him, and she explained to him that he had so many weeks left of treatment and that he was done, basically telling him that in her opinion he was healed. And really, in a perfect world, he would be telling her how he feels he's doing and where he's at in his treatment, and they would collaborate on that and come to more of a mutual agreement. And so when she said that he had like 3 more weeks to see her, and how exciting that he was going to have to see her every week or once a month, whatever his scheduled appointments were, he just shut down and just didn't talk anymore. He didn't tell her what he was experiencing or how he was responding to the information that she was just sharing with him. And so it's horrible. And so we need to be careful with how we communicate information to the LGBTQ person as well, because we don't want to shut them down. We want to keep that communication flowing, and we want to understand, where they're at, where they want to be, and what they think it's going to take to get them there, so that they have an improved quality of life and they have improved health. One term that I was not aware of, and it's a MSM, you probably know what this is, but it's men who have sex with men. And these males may not identify as gay. They may very well identify as heterosexual and possibly even be married or in exclusive relationships. And so I just wanted to bring that up because that was something new that I had learned. And so this, according to the literature, is especially true for the Black and Latino male. So we don't want to assume that if we have a male having sex with another guy, that he considers himself as anything but heterosexual. And I'm sure that the same is true for women as well. Okay. So here's some ideas for creating a welcoming clinic environment. And I probably won't go through all of these because I'll let you have copies of these slides and you can refer to them. But maybe posting like a rainbow flag, pink triangle, or unisex bathroom sign, or some other kind of LGBT friendly symbol or sticker. Maybe having some posters that show racially and ethnically diverse same-sex couples Also different posters from nonprofit LGBT and or HIV and AIDS organizations, having brochures that have different LGBT health concerns, such as breast cancer, safe sex, hormone therapy, mental health, substance use, sexually transmitted infections, such as HIV, AIDS, syphilis, and hepatitis A and B. And also, I'm going to provide you with some resources as a handout, and so you can refer to that, and where you can find brochures and other materials from the Center of Excellence on the LGBTQ community. So, maybe in your office, acknowledge like Pride Day, and different things like that, World AIDS Day, different things like that, so that you're having things included, being inclusive as opposed to exclusive. So, best practices, and I may repeat myself on a few of these, but just be open and tell your patient if you're inexperienced. Your readiness to learn will often stand out from their other previous healthcare experiences. Trauma-informed care should be available because trauma, substance abuse, and mental health issues tend to be at a higher percentage for the LGBTQ population than the general public. Conduct a violence screening. Violence screening questions should be general neutral. There's a great deal of violence that's reported, so continue to assess for chronic PTSD and grief and make referrals if needed. Also conduct a mental health screening. That might be like, say, using the Columbia or the PHQ-9, and conduct a substance abuse screening. The LGBTQ people are often targets of harassment and violence, and they are not exempt from interpersonal, partnered, and domestic violence. And many of them have been battered and may fear being outed if they report the violence to providers or authorities. They could be concerned that or would retaliate by telling their employer, their family, their friends, or other people that they're gay. So ethically, we need to discuss with all of our patients when we have to report, for example, when someone is a danger to themselves or someone else. And so it's also vital that we assure the patient of confidentiality and possible, depending on your state laws regarding reporting, and as well as disclosing like substance use disorder information. The federal law is very much more protective of that information than some of the physical health information. So transgender people are sometimes subject to some of the most extreme levels of social exclusion. This exclusion can destabilize them as individuals and create a host of adverse health outcomes. Risk and response behaviors to watch out for include cycling in and out of employment, and therefore having and not having health insurance, having a history of interrupted medical care, avoiding medical care, pursuing alternate gender confirmation therapies like injecting silicone or taking black market hormones, engaging in survival sex, interrupted education, social isolation, trauma, and extreme poverty. Health interventions will need to consider the combined impact of health risks resulting from the stigma that they experience and the host of other levels of exclusion and that they are exposed to. So when we're doing a violence screening, some of the language that we might want to use would be to ask all of our patients about violence and then use open-ended questions, such as, have you been hurt physically or sexually by someone you're close to or involved with, or by a stranger? Are you currently being hurt by someone that you're close to or involved with? And so, we want to avoid using husband, wife, and married unless the patient uses these terms. And so, using terms like roommate, partner, significant other, rather than husband, wife, and married might help with a more open communication. You could also say things like love relationship, committed relationship, exclusive relationship. Those are good terms to use that would not be traditional married language. And so, if there's high levels of trauma that's been repeated through multiple batterers, you might want to assess and explore physical and mental health issues related to long-term PTSD and the unresolved grief issues that accompanied these relationships. So some information that I found interesting and more best practices were that LGBTQ people are particularly vulnerable to social stress that often leads to increased tobacco and substance use. A recent large study showed that LGBTQ men smoked 50% more than other men. LGBTQ women smoked almost 200% more than other women. That's a lot. So, just be prepared to provide treatment options and consider the use of stages of change. Maybe look at a harm reduction model that might help your client if they're not ready to stop smoking. Possibly make a referral for medication-assisted smoking cessation. If your client thinks that would be helpful. And again, the use of motivational interviewing can be really helpful. So likewise, explore whether the LGBTQ patient is dealing with social stress through alcohol and drug use, and be prepared to present treatment options. Know if your state has any state-funded sliding scale treatment centers or detox centers. Know where they're located. Do they have a waiting list? What are their phone numbers? Just all those things that the individual may not know or understand, so that you can help them through that without there being a huge hurdle or a roadblock, so that they can get the help they need. And also, the social stress that they're experiencing could contribute to their body image, their exercise or lack of it, as well as their eating habits. So we want to look at the whole person, body, mind, spirit, mental, physical, not just their sexual orientation. And then remember, when making treatment recommendations, that they're contributing factors that feed into their challenges that they have include a lack of support, lack of resources, harassment, substance abuse, mental health disparities, and the need to assess for suicidal ideations regularly and openly. That needs to be a comfortable topic for you as well as the patient. So just as a refresher for the stages of change, the stages are pre-contemplation. That means I'm not even thinking about it. I am not thinking about giving up smoking. Contemplation stage is where I'm thinking about it. It's like, well, yeah, I understand it might be good, for me to quit smoking or to not smoke as much as I do. I'm kind of thinking about it. And then action stage is, yeah, I'm going to quit smoking. I've set a date and I'm going to give up smoking for good. And then the maintenance stage is where I quit smoking and I've been smoke free and I'm going to continue to be smoke free. So, harm reduction, that's been getting a lot of attention, but it's reducing the amount or frequency of use, maybe still using drugs, but having clean needles. It could be not getting a DUI and being able to drive to get to work. So, anything that reduces the harmful effects of a substance to me and my health and my lifestyle, my family, my job. So also look at medication assisted treatment for smoking and alcohol and drugs if needed. And then again, we want to look at the whole person using person-centered treatment, consider their body, mind, and spirit of this person sitting in your office. And with motivational interviewing, you can explore where they would like to start, what they would like to see change or happen or stop happening. What does this person need to do that? Do they need housing? Do they need a coat because it's really cold out? Do they need some type of medication, social interaction? Are they needing a job or case management or peer support? So individualized treatment that fits the individual and their needs is going to be really vital. So takeaway. So today, despite increased prevalence of mental health issues, including mood disorders, substance abuse, and suicide, members of the LGBTQ communities are less likely to seek healthcare treatment. Discrimination or fear of it, lack of financial resources and healthcare insurance, and the tendency for providers to focus on sexual orientation contribute to healthcare disparity in the LGBTQ community. So culturally sensitive communication skills, a welcoming environment can both reduce fear of discrimination and improve dialogue between the patient and the provider. So the LGBTQ individual has possibly experienced a lifetime of shame, discrimination, ridicule, refusal to provide services by medical and behavioral health providers, as well as people just not wanting to touch them or talk to them about their life, their lifestyle, or what's important to them, is all a big part of why they frequently do not seek healthcare treatment. So what we want to do is watch for stigmatizing language that we might accidentally be using and be open to looking for other manners to express what we are trying to ask or say. So like I said, being open to shaking your head no and learning how to ask those questions without it being a loaded question where they already know the answer that you're looking for from them. So additional takeaways are in a survey of over 50% lesbian, gay, and bisexual individuals, and over 70% of the transgender individuals. They reported discrimination in healthcare, refusal to provide treatment, as well as lesbian, gay, and transgender persons have reported harsh language being used by healthcare providers and also being blamed for their health status. Some reported that healthcare providers refused to touch them. During visits, the healthcare provider might focus more on their sexual orientation and gender identity rather than what they come to the office for, what they're there for. So remember that they are less likely to seek medical care in fear of discrimination, and that they're also less likely to have health insurance or be able to afford medical care. So sometimes there's maybe a list that you can pull together of individuals that might do some pro bono work for counseling or some sliding scale medical services or SUD services that they could check out and receive services from. So suicide's a major concern with our LGBTQ individuals, as suicide is the leading cause of death in LGBTQ age individuals ages 10 to 24. That's horrible. It's not illness, it's not being in a car accident, it's suicide. So in transgender individuals, up to 65% experience suicidal ideation, and 40% of those have reported a suicide attempt. Most attempts were before the age of 25. So I'm not saying that anyone beats up their clients, their customers, or their patients, but just be sensitive to knowing that contributing factors include a lack of support, they're being harassed, them using substances, and there being mental health disparities. So there'll be a time for questions. And so I hope if you have any questions that you will ask those. And so then to finish up, I'd like to share some resources. And so SAMHSA has Centers for Excellence, and they have a Center for Excellence for LGBTQ plus and behavioral health equity. And so what this center offers is they provide behavioral health practitioners with vital information on supporting the population of people identifying as lesbian, gay, bisexual, transgender, queer, questioning, intersex, two-spirit, and other diverse sexual orientations, as well as gender identities and expressions. So I'll go more into the two-spirit in a slide or two. So I've also added the website to a list of centers of excellence that you might want to look at and see if they have any information that you feel like your practice could benefit from. And it also, so anyway, their mission is to bring information and resources to the behavioral health field to enhance culturally responsive care and decrease disparities for this population. So their goals is to increase awareness and understanding of the LGBTQ plus disparities, unmet treatment needs, minority stress, evidence-based programs and best practices, workforce challenges, opportunities among practitioners, families, youth, the states, and communities through regular provision of free, publicly available, coordinated training and technical assistance, increases in practitioner knowledge and skills about effective strategies to decrease health disparities and stigma through using evidence-informed, evidence-based, and best practices, and to accelerate the adoption and implementation of evidence-based practices through the use of clinical models, as well as training and coaching for the workforce. So here's some things that they offer: training and technical assessments. They have some monthly webinars to provide information. They also have self-paced training modules. They have monthly office hours with experts so that they can offer you technical assistance on different subjects that you may need some help with. And then here's a list of some of the different centers of excellence and their websites. You can check these out. This is the LGBTQ site. Here's the African American one. Here's the tribal, peer recovery, and smoking cessation, and so on. So, in addition to the centers of excellence, SAMHSA has the technical transfer centers in each region, and these are for prevention, treatment, and mental health. And they will provide you with education, support, and resources, and they're very valuable in our line of work. So here's the technical transfer centers. You can see here in Region 10 that we have 3, and they are through the University of Washington. And this one, ATTC, is Addictions Technology Transfer Center. The MHTTC is Mental Health Technical Transfer Center. And the PTTC is the Prevention Technical Training Center, Technical Transfer Center. And then there's also a National Coordinating Office, a National Tribal Affairs Center, National Hispanic and Latino. I think there's a new one on eating disorders. There's the LGBTQ. There's dozens of technical transfer centers. Some have a national focus, while others are more regional. And then here's another listing of different technical assistance centers that you can use and refer to if you need additional information. And so SAMHSA, along with other agencies and private sector partners, fund training and technical assistance centers through grants and contracts to serve the mental health and substance use needs of our targeted audiences. So above is a partial listing, and I've highlighted those in red that do significant work in more rural communities. So here's the National American Indian and Alaska Native Technology Transfer Center. And so please reach out to them if you have any questions regarding Two-Spirit or other tribal information. Tribal refer to their LGBTQ individuals as two-spirited individuals, that they are male and female. So that's how they refer to theirs, as two-spirited. And so here is the Rural Opioid Technical Assistance Center. If you have any need for help with opioid treatment, or how to get medication-assisted treatment for opioids. Next, I have lots of hotlines and phone helplines that you can call for disasters, veteran crisis lines, suicide, and so on, buprenorphine. And as of July 16th, which just passed, we have a new opportunity. That's the 988, where you don't have to call the 800 number. You can call 988 if you're in a mental health crisis or someone you love is. And so they will be there to help you through that, rather than intervening with the police unless someone is in danger, imminent danger. And so we're in an exciting time to be a part of this rolling out. And so be sure and let people know about the 988 number. You can still call the 1-800-TALK. That's also fine. They roll into the same call centers. So, but each state is answering the 988 calls. And so you'll have local help and resources and people that have boots on the ground where you're at and know what the resources are and how to help you. So, so remember SAMHSA, we're here to help, and our mission is to reduce the impact of substance abuse and mental illness in America's communities. Don't hesitate to reach out to headquarters, or feel free to email me or call me. I'm Lois Gilmore, and here's my email, my cell phone number. I do have an office number, but we're working remotely mostly. We go into the office about 1 day a week. So it's probably easiest just to catch me via my cell. So thank you again for being here. I hope that I gave you some information that's helpful and that you can use. Thank you very much. Bye.